Because we are going to begin our journey into psychiatry. And when we think about the neurobehavioral sciences, and when we see patients, as in any discipline in medicine, we have an algorithm of putting information together so that we can make an accurate diagnosis, so that we can have an informed treatment approach to give our patients the best care possible. When patients present to us, when we're analyzing a case, when we're taking an exam, when you're taking a shelf exam, a board exam, first thing you want to think about is the age of the individual, because age gives us an idea. Are we looking at a disease that typically begins in childhood? Are we looking at a disease that may begin in adolescence? Are we looking at a disease in adulthood? Are we looking at diseases we typically think of in the elder care patient? In psychiatry, we have our child and adolescent diseases. We think about attention deficit hyperactivity disorder, ADHD, in childhood. We think about tic disorders. We think about the reality today that depression can begin in childhood, as well as thought disorders. Anxiety, and we see certain types of anxiety disorders that are in childhood, especially when we think about anxious school refusal, youngsters who have difficulty getting up in the morning to go to school. We think about gender. Gender is important too, because presentations may vary based on one's gender. And so we think about that. We know that the numbers, the statistics tell us that some disease states are more prevalent in men, some disease states more prevalent in women, and across the full gender spectrum. So we think about gender as well. And the symptoms, those are critical, because that's what brings the patient in. So we need to think about the symptoms. And when we think about symptoms, we look at time frames. When did the symptoms begin? How often do the symptoms occur? How long do the symptoms last? Time frames are going to be very important when we're looking at psychiatric illnesses. When we think about depression, we think about symptoms that occur most of the day, every day, for at least 2 weeks to meet the criteria for a major depressive episode. When we think about anxiety disorders, we're also going to look at time frames. Does the individual's episode, as it were, peak in 4 minutes, last for 10 minutes, and then resolve? Thinking about a panic episode. If we're thinking about issues of acute stress disorder, post-traumatic stress disorder, time frames again become critical, because an acute stress disorder is 3 days to 30 days and then resolves. Post-traumatic stress disorder lasts longer than a month and oftentimes has a delayed onset. And then when we start thinking about thought disorders, we have the time frames there. When we think of psychosis, brief psychotic episode or reaction is from 1 to 30 days. If it goes beyond 30 days, yet less than 6 months, we're thinking about schizophreniform disorder. If it goes beyond 6 months, now we're thinking about schizophrenia. Time frames are very important. You will know them by the time we're done with the course, and you'll be comfortable with them. And this will help you when you're taking shelf exams, board exams, because no matter how convoluted the question may be, the time frames still have to be there. And so you'll know them and you'll be comfortable in taking your boards. Past episodes, past treatments. It's important not to reinvent the wheel. So we want to know, and this is a classic question, have you had this before? And if the individual says yes, then of course we can say with some certainty, oh, you've got it again. Now the key is past treatments. Was something effective in the past? When I see patients and when we talk about the mental status exam, one of the questions I ask patients in their initial evaluation is, what meds have you been on in the past? What medications have been used? And then I ask, did they help? Just because medication helps doesn't mean that the patient will continue with it. Oftentimes they're not able to afford the medication. And so part of our task as a physician is to help them to be able to afford their medication. Oftentimes patients may move, and so they don't have a new physician. and so they don't renew their medication. It doesn't mean the medication wasn't effective. And instead of reinventing the wheel, I'll ask patients, what medicines have you taken in the past? Which ones were effective? How effective were they? Because if the patient says to me, in the past, Dr. Goldman, for my bipolar disorder, which is a mood disorder with moods going up and down, I was on lithium. It was very effective. I just let my prescription run out. So it may be prudent to reinitiate lithium instead of trying all different types of medication trials that may be successful and may not. So we want to ask, what are past treatments? We also want to know, by the same token, in the past, did you have any adverse responses to medications? Because if you did, we're certainly not going to use those medications again. We ask the question, does anything make your condition better or worse? This gives us important information. The patient presents to us, he or she tells us that he or she is hearing voices. When voices are being heard, we ask, does anything make the voices better or worse? Oftentimes patients will tell us, yes, I plug in my headphones, I listen to music, and that helps. Again, one of the reasons this can be important, and we'll talk about this when we talk about medical jurisprudence and medical ethics the first week in April, is because we need to know if someone is malingering. That means making up their disease. And we often know if the individual says, well, this makes it better, there's a greater likelihood they're not malingering, they're not making it up. Whereas if the individual says, well, I hear voices 24 hours a day, 7 days a week, nothing makes it better, we have to start thinking, because that is not the usual and customary presentation of auditory hallucinations. Family history, the genetic potential and learned behavior. These are key elements. Again, regardless of what area of medicine you find yourself practicing, there's a genetic predisposition for so many of the disease states that we diagnose and treat. So too in psychiatry. We typically see a family history of depression. We typically see a family history of anxiety. We can see a family history of bipolar disorder. It oftentimes can be generation skipping, yet we know there's a genetic predisposition. OCD, obsessive compulsive disorder. We'll be talking about all these disease states throughout the next several weeks. We tend to see a genetic predisposition. Learned behavior as well. Children will observe their parents. They will see certain types of behaviors. The parental behavior may be disease-driven, yet the child learns how to respond in life to the parents' behaviors and then incorporates those into his or her own life. And hence, these can be learned responses and behaviors that go to the fibers in the fabric of the matrix of the individual's personality. We'll be talking about that as well. Then, the big three. Hallucinations, homicidal ideations, suicidal ideations. We want to ask those every time we see patients. It's important. If an individual is experiencing hallucinations, especially auditory hallucinations, we need to know. Because we need to know, are voices telling you to hurt yourself or someone else? Safety is critical. So too with homicidal ideations. It's important to ask patients, are you having any thoughts of wanting to hurt anybody? Wanting to blow up any buildings? It's important to ask, are you having any thoughts of self-harm? Are you wanting to hurt yourself? Do you cut on yourself? Do you want to die? You see, most often, patients will respond. They will tell us. We'll have a lecture on suicidal and violent behavior during the next 2 weeks. The single greatest predictor of future behavior is past behavior. So we need to keep that in mind. The single greatest predictor of violent behavior is past violent behavior. The single greatest predictor of potential for future harm is past harm attempts. So we want to keep that in mind. So it's very important to ask, are you having any thoughts of wanting to hurt yourself? And I ask that of my patients every time I see them. Contrary to popular myth, by asking a patient, are you having any suicidal thoughts, the patient is not going to go, What a great idea, I never thought of that. Now, oftentimes, they will now be willing to admit to having these thoughts. We need to know that. We need to think neurophysical, neurochemical pathways, because this is, we think, the biological underpinning of the disease state and the biological key to treatment. And Dr. Mentalism will talk with you all, as he already is, about pharmacologic approaches based upon the neurophysiology and the neurochemistry. And we'll look at that in a minute in another slide. SAM cells, what, pray tell, is that acronym? That stands for sleep, appetite, memory, concentration, energy, libido, and the S in the parentheses reminds us to always ask about suicidal ideations, homicidal ideations, and hallucinations. This gives us, regardless of whether you're doing a psychiatric evaluation, if you go into family practice, pediatrics, OBGYN, whatever you go into, getting a good handle on the patient's sleep habits, appetite, memory, concentration, energy, and libido is going to give you quick data that will help you formulate a very rapid diagnosis for your patient. Is sleep up or down? Is the individual not sleeping? Is the individual sleeping too much? Is the individual not eating? Is the individual overeating? Is the individual gaining weight and yet he or she says there's been no change in his or her appetite? Is memory disrupted? Concentration disrupted? Energy gone or over the top? And libido, is it up or down? Interest in sexual activity? What we may be looking at is a thyroid disorder. And this helps because hypothyroidism, you may see changes in all of those neurovegetative functioning inventory indices. So again, utilizing sleep, appetite, memory, concentration, energy, and libido is good no matter what area of medicine you went to. You may ask, Dave, where did you come up with this mnemonic? I came up with it when I was in residency. I did a traditional transitional rotating internship here in Kirksville, long ago in a galaxy far away, before your grandparents were born. And then when in my day, there were 14 states that as a DO, if I didn't do a DO, traditional transitional rotating internship, I couldn't get a license, a medical license to practice in those 14 states. One of those states was Tennessee. I went to Tennessee for my residency there at Vanderbilt, which was an MD program. However, I had my program approved by the AOA before going. Now it's all one, so you all don't have to worry about that. And they requested I do their internship, so I did a second internship, which was fine with me because I learned that much more. And I went there already fully licensed as a physician. One of our attendants, I was an intern, was Dr. Sam Sells. And we had to do service at night, every 4th to 7th night. We were the officer of the day in the psych ER. And so we saw patients literally as a walk-in clinic all night, 5 in the afternoon to late the next morning, and then went back to our duties on the unit for another 12 hours. And after seeing patients all night, we would meet with Dr. Sells at 8 a.m. before going on to the rest of our duties, and he would ask the same questions every time of all the patients. How is their sleep? How is their appetite? How is their memory? And I thought to myself, after I was already fried from being up already 24 hours and having another 12 to go, the first letter of each of those words spells his first name, Sam. Sleep, appetite, memory, Sam. And then he'd ask about concentration, energy, libido, and suicidal ideation. That phonetically spelled his last name, Sells. And I thought, gee, Sam, you don't realize you are my living mnemonic. Just looking at you, I can put together every patient case. And that's how I came up with that. And that's what I've been using ever since. So again, sleep, appetite, memory, concentration, energy, libido, suicidal ideations, homicidal ideations, and auditory hallucinations. Now, it's important to rule out underlying physiological illnesses before we tell patients that their problem is supratentorial. We have to let them know that it's not an underlying thyroid disease, that we're not looking at a tumor of the head of the pancreas, that we're not looking at an adrenal disorder insufficiency, that we're not looking at a vitamin D deficiency. We have to rule out all of those underlying potential physical disease states that mimic our psychiatric disorders. So that one leads us to think about labs. And we'll look at that momentarily. After we do that, we need to formulate a differential diagnosis or diagnoses. And we formulate that, and once we formulate that, then we start thinking about our treatment approaches. Efficacy versus effectiveness, not to worry. That's looking at the potency of a medication, either with or without the potential risks and side effects. Effectiveness is without potential side effects. Then we come up with our treatment plan. We're going to use Better Living Through Modern Chemistry. Will we apply psychotherapy with it? Do we need to intervene and bring the whole family in? Do we need to intervene to help fix social issues, such as homelessness, joblessness? These are issues that are psychosocial stressors adversely impacting patients' mood, thought process, and daily activities. You already know SAM cells. You'll probably be able to recite that in your sleep. Labs. We need to order labs. Today in psychiatry, before we intervene to treat, we obtain labs, and then once we begin treating, we have to continue to get labs, be certain that our medications are not adversely impacting the patient's organ systems. 5-axis diagnostic approach. You'll notice in the red print, discontinued in the DSM-5. What is the DSM-5? The DSM-5 is the Diagnostic and Statistical Manual 5. The DSM has gone through all its incarnations. When I was a student, it was the DSM-3. When I was a resident, it was the DSM-3R, revised. Then it became the DSM-4 when it was time for me to sit for my board, so I had to buy a new book. Then it became the DSM-4TR transitional, so when I went out into practice, I had to buy a new book. Now it's the DSM-5. Again, this is the cookbook, and I'll pull up a slide momentarily to go over it a little more. Do you have to have a copy of this? For this course, no. When you're out rotations, it would probably be very handy. So if you talk to them at the bookstore or whatever, the pocket guide is great for when you're out on rotations if you need it. However, what the DSM-5 has done, it has changed a lot of the components that existed in the DSM-4 and the DSM-4 transitional and the practice of psychiatry, one of which was the 5-axis diagnostic tree. What did that mean? We had 5 components of making a diagnosis. Now, interestingly enough, the DSM-5 has abrogated that. It doesn't exist anymore. Except where I practice, they still ask for the 5 axes. And when I do evaluations for the Veterans Administration, I want to know, is this an Axis 1 disease? So again, while the DSM-5 has done away with it, it's still important to understand the DSM-5, the 5 axes, because they help us create a 3-dimensional perspective of our patient's life. Axis 1 is the state, the acute presentation of symptoms. So axis 1 is when a patient presents, let's just say, with a major depressive disorder. He or she has been having disturbances in the 6 neurovegetative functioning inventory: indices, sleep, appetite, memory, concentration, energy, libido, most of the day, every day for the past 2 weeks. When asked, are you having any loss of interest in daily life activities? He or she may say yes, and then he or she may say, and by the way, I'm depressed. They meet the criteria for a major depressive episode, for major depressive disorder. That would go on axis 1. Axis 2 is the personality disorders and intellectual capacity deficits. So it would be on axis 2 that we would put someone has borderline intellectual functioning, or someone has borderline personality disorder. That would go on axis 2. And when you're out in rotations, you will still hear the psychiatrists with whom you rotate saying, yeah, that person's all axis 2. What they're saying is, What's wrong with that individual is his or her personality issues. So again, you'll still hear Axis 2 used. Axis 3 is medical diagnoses. The individual has tuberculosis. That would go on Axis 3. The individual has comminuted fracture, Axis 3. Axis 4, the psychosocial stressors, such as loss of a job, loss of housing, individuals in the throes of a divorce. That's a psychosocial stressor. It goes on Axis 4. And Axis 5 is a global assessment of functioning. That's a numerical scale, again, abrogated by the DSM-5. However, we still talk about global assessment of functioning and numerical value. And it is a scale from 0 to 100. And so insurance companies will oftentimes ask for their GAF scale to determine whether or not the individual meets the criterion of going into the hospital. So these are the 5 axes. It helps to get a three-dimensional picture of the individual, their acute state, maybe depression, maybe anxiety disorder. What about are there personality issues or intellectual capacity deficits? That's your Axis 2. Are there any physical problems? Because these physical problems have a negative impact on life function. That's on Axis 3. And what about the psychosocial well-being of this individual? His or her family life, work life. That goes on Axis 4. And then it's all summated on Axis 5. Yeah, that individual's maybe about a 45. Don't worry about the 45. However, that gives you the perspective of what's going on with the 5 axes. Treatment approaches. And these are the areas Dr. Mentalism will be reviewing medications for you and treatment interventions. Mood disorders we treat with antidepressants because one of the common forms of mood disorder we see is depression. We also treat with antipsychotics because we can have major depressive disorder with psychotic features. That means the individual's thought processes are distorted. They may be hearing voices, they may be seeing things. We may use anti-seizure medications. Does that mean someone's having a seizure? No. Many of the anti-seizure medications have been FDA approved for mood stabilization as well as mood enhancement. So too with the antipsychotics. The atypical antipsychotics have all been FDA approved as major mood stabilizers. So in bipolar disorder, we use the antipsychotics frequently to stabilize mood and to improve mood. Lithium, been around since 1948-49. John Cade of Australia discovered that this element that appears on the periodic chart and is found in the soil and the water, it helps stabilize mood. We've been using it ever since. And again, we'll be talking about risks and side effects as well, which helps to determine which medications we use. Anxiety. Again, antidepressants can be used. Many have been FDA approved for treating anxiety. Benzodiazepines, BZDs. We still use those. However, we seek to avoid them if we can because of their potential for tolerance, dependence, and withdrawal, the 3 components for addiction, substance use disorder. Buspirone is used for anxiety. And then off-label, we may use some of the antipsychotics, small doses, to help treat anxiety. Thought disorders, again, of course, the antipsychotics. We may combine those with antidepressants. We may combine with anti-seizure medications. We may even combine with lithium. The DSM-4 TR, the only reason I put this up is because the wording helps us understand. It is dealing with guidelines for making diagnoses. However, as it says in the last sentence, inclusion here does not imply the condition meets legal or other non-medical criteria for mental disability. That comes into play if you are asked to testify in court as to a person's capacity to perform certain functions. The DSM-5, which is now the Ascendant Diagnostic and Statistical Manual, again, it says the symptoms contained in the respective diagnostic criteria sets do not constitute comprehensive definitions of underlying disorders that are far more complex than can be described in these brief summaries. That's the disclaimer that The individual may not completely meet the criteria as laid out here, however, we can still make the diagnosis. Come back to that. If, again, please, this is not a sales pitch, I'm not pushing this, I'm just saying, if you need sources, all of my lectures come from the textbook, which I happen to know the guy who wrote it. He did his best to cull it down and make it board-friendly as well as shelf-friendly, to have everything in it you need for boards. This is a review guide with questions and all. The bookstore has it. It's downloadable onto your iPads and computers from Amazon and all at very low cost. I didn't make anything on it. Wrote these to help with boards and to help with shelf exams. And then this we'll talk about in April for medical jurisprudence and medical ethics. We are blessed to be one of the schools that actually has a course in that. Most med schools do not. You'll find that it will be a benefit on boards as well as when you're out in practice. I handle a lot of legal issues on a regular basis in practice. And that's just as a psychiatrist, not as an attorney. This schema is from the DSM-4, and you can see how neatly put together, how almost simplistic it is. The mood disorders, the anxiety disorders, and the thought disorders. Then along came the DSM-5. Whoa! It really kind of made it a lot more confusing. So I took the DSM-5 and did my best to put it together into this schema. And this is what we'll be dealing with and lecturing from over the next 2 weeks. Human energy. We're going to be talking about psychiatry, and we're also going to be looking at it from an osteopathic perspective as well. So that when I engage in diagnosing patients and in treating them, I do so osteopathically, because I look to my therapy. Is it going to be highly confrontational or high velocity, low amplitude type of therapy? Is it going to be more of a muscle energy approach, where I take the patient up to the barrier, feel for the resistance, and let them push, and then I release them? Is it an indirect technique, where the patient comes in, and I just let him or her go off in whatever direction he or she wants to? Is it more of a counter-strain technique, where I find where their emotional pain is, and then move them away to a comfortable place, and then at the end of the session, bring them back and see if they're more at ease with it? So again, I assess and analyze from an osteopathic perspective. And I also realize that as DOs, we lay on hands. We diagnose by feeling for the somatic dysfunction, by palpating our patients, and then work to release the somatic dysfunction energy. What makes us uniquely alive and human is the bioelectrical chemical axis that exists within our bodies and our brains. The neurons, the synapses, the neurotransmitters, these regulate mood, motor function, cognitive function. So we're going to be talking about all of this, and Dr. Mentalism will be looking at gamma-aminobutyric acid, GABA, and the medications that focus on that and helping to stabilize mood. We'll be looking at glutamate, the excitatory neurotransmitter, and if it's dysregulated, what's happening. Dopamine, norepinephrine, and serotonin, the three key neurotransmitters we think about in psychiatry when we think about treating mood disorders, treating anxiety, and treating thought disorders. Energy. I have a small tube, and the small tube can conduct electricity. And when it does, you'll be amazed what can happen. And I'm going to ask, if I may I please ask you to come forward? May I ask you to come forward? And I promise no one will be embarrassed. What I'm going to ask, if I may, we're going to show energy. I'm going to ask you with your right hand just to take hold of that so it's circled perfectly. And then I'm going to ask you with your left hand to circle that productive area. Nothing is happening at this point in time. Now we're going to see the energy that exists within both of you begin to flow, because I'm going to ask you to each take your other hand and take your index fingers and touch them. See, when that happens, that energy flows, and now, if you release the index fingers, it stops. But wait, there's more. Operators are standing by now because may I ask you to come forward, and may I ask you to come forward. And then I'm going to ask you each, I'm going to have you hold up your index finger and just touch. I'm going to have you hold up, yes, and now, nothing is happening right now, am I correct? And now, I'm going to ask both of you to touch index fingers. And you see it's even louder and brighter because the energy is greater. And you may release. And we could take everyone in the room and circle the entire room and just have the last two individuals touch index fingers and probably blow this up with the energy. Please, a round of applause for our colleagues. Energy. This is what makes us uniquely human. And this is what we, as osteopathic physicians, look to and utilize in bringing our patients health and well-being. Energy. Now, when we think about energy, we realize one of the key elements of life is water. It is a richly complex substance upon which we rely daily. All of the earth relies on water. Scientists can help us understand the reason that water is so essential to life, and yet we do not fully comprehend its chemical and physical properties, nor can we really explain where it comes from. What we do know, at the University of Georgia, they found that in every human body, all disease cells, no matter what the disease, the cells were surrounded by what is called unstructured water. That means it's missing one electron in an outer orbit. And what they found was that all healthy cells were surrounded by structured water. Now you can see on the right the amount of water in the body, whether it be heart, skin, lungs. Water makes up the majority of our body. This piece of wood once was alive and vibrant. It was in a tree. The tree is critical because the tree helps give off oxygen and recycles our carbon dioxide. What is this piece of wood missing? It's 2 by 2 by 6 that now renders it inert. It's missing water. Because with water, it could still be alive. Now, we are going to attempt an experiment here. We're going to take this piece of wood and we will lay it against the bottle of water. And we will take the energy within us, and I want you all, please, to concentrate on the piece of wood in the bottle of water. And I'm hoping that the energy that you all are generating will excite the molecules in the bottle of water. And if they can excite it enough, it may be able to shift just enough energy to that piece of wood to bring it enough life that we can see it move, whether it be a millimeter or more. We're hoping maybe we can cause that piece of wood to move. No. Well done. Please, a round of applause for yourself. Please. Yes. Good job, man. Energy. When we think about energy, we know that there's positive energy, which you all just harnessed and caused enough excitation for that piece of wood to move. We also know there's damage from energy. There's negative energy. The forces exerted on the brain by shock waves are known to damage the axons in the affected areas. And this is an area now that I see more of and that I deal with. I'm honored that our mental health center, we work with the Veterans Administration, and I do evaluations for post-traumatic stress disorder, traumatic brain injury. And we know now that there's more to a traumatic brain injury than just the physical impact from an object contacting the cranium and causing damage inside the brain. We know now that concussive energy waves can also cause damage within the brain. And so this is something that we're learning more and more about. And you'll notice I have a light bulb sitting inside of this plastic container. And the reason I have the plastic around the light bulb is simply because we're going to see what negative energy can do in a moment, and I do not want it to shift out to us. So I'm going to ask you all now, if you will, I want you all, please, to focus your energy inside the plastic container. And what I want you to do, please, is to take the negative energy. If your toast was burned this morning and aggravated, if in coming to school this morning, if it was so cold, it was aggravating, and you thought, why am I getting up this early to come with this biting wind? I want you to take that energy, that frustration, and I want you, if you will, to focus it. And I want you to focus it inside that plastic container. And as you do, I want that negative energy to build up inside of there. And you see, negative energy has just as much impact as positive energy. And you all did that, and well done. And now you all should feel a lot better, because the negative energy is released, it's gone, and we contained it inside of there. Those of you that are familiar with the work of Jason Haxton in the Dybbuk box, we're keeping all that negative energy contained in there. Psychotherapy. And I appreciate you all bearing with me. This will all take about 4 or 5 more minutes. Is that okay? I know the bell will ring. Psychotherapy, and we'll have a lecture on that in psychiatry, is no less painful than surgery. We just hope it is without blood. Psychotherapy is an environment wherein the patient comes to us, and we, as the therapist, help them process thoughts and energies within themselves, and we guide the individual, hopefully, to release that negative energy and to reestablish his or her life. Prescribing medications requires scientific and experiential understanding to facilitate improvement in mental health, while we avoid potential risks and side effects in med-med interactions. Psychiatry is the combination of art and science, mind, body, and spirit, very osteopathic. Talk therapy, pharmacotherapy. This is how we help patients in psychiatry find renewed health. I have here 5 little stands. And I have a heavy titanium spike. Please, very gently, if you will, I'll ask you to hold your hand out. Heavy, yes? Yes. Yep. And ask you to gently touch the tip, very gently. Sharp, yes? Yes. Very gently. And you will verify for all your colleagues throughout the room that, there we go, yes. Sharp, heavy, dangerous. Now I'm going to ask for one of us may have a volunteer, I promise, no volunteers will be injured in the making of this demonstration. May I ask for a volunteer? May I have you come forward? Is that okay? Yes, yes, thank you. And please note, I'm not trying to pick on folks on the aisle. It's just easier for transport back and forth. What I'm going to ask you to do, if I may, I will step forward so I cannot see what you're doing. You may do the following. You may just move these in any place you want, and then set them here so that you know where the spike is. I will not. Then I'm going to ask you to cover these so I have no idea where the spike is. Okay? You will know. Once you're ready, I just want you to say, all set. Okay? And I just ask that you keep enough space between them so that I can put my hands in here to feel. Okay? So you can move them around, or if you want, you may pick up the spike and just set it wherever you want to put it. If you do that, please be careful. You'll notice it's very sharp. I will step forward so I cannot see. And when you are ready, when you have placed the spike where you want it, then I just want you to say, I'm ready. And you've covered it with the cuffs.
Okay.
All right, thank you. And thank you so much for being willing to do this. Thank you. Please, a round of applause. Psychotherapy. When patients present to us for psychotherapy, it is our task to ask the questions that we ask, to assess and evaluate the individual so that we have a good, thank you, we have a good understanding of who the individual is. And when we are performing psychotherapy, we look at it as osteopathic physicians. We take the patient up to the barrier and we do our best to find a position of comfort and ease for the patient so that we know that the patient is making progress. And our goal is to help the patient find that level of ease so that the patient now is able to engage in his or her life in a more productive and functional way so that we're able to step the patient away from that level of pain and discomfort. Thank you. Will only encourage me to do more. This is our last slide. This will be our last effect. We'll also talk about dreams. Freud talked about the royal road to the unconscious, and that was dreams. And when we lecture on Freud, we'll talk about the components of the mind, the unconscious, conscious, preconscious. We'll talk about those. In so many ways, dreams may seem like a shuffled deck, cards dealt at random, making absolutely no sense. And those are the types of dreams that we call latent dreams. Patent dreams are very clear dreams. We know exactly what the dream means. On our way to class, we step off the curb. We're almost struck by an automobile that came whipping around the corner. And that night, we go home, we go to bed, and in our dream, we dream about stepping off the curb and almost being hit by an automobile. It's because the energy that was infused into us has to come out, and it comes out as a very patent dream. And then we have some discharges that have absolutely no meaning whatsoever, just the movement of some neurons, and those are meaningless dreams. But I'm going to ask, is there someone here amongst us today who has a comfort level with playing cards? It doesn't mean it's the product of a misspent youth. Anyone here comfortable with playing cards, knows one card from another, and would be willing, you won't even have to leave your seat, would be willing to part? Excellent, thank you, thank you. I'm going to ask, if I may, I'm going to throw you a box of cards. Is that okay?
Yeah.
And I'm going to ask you to catch the box of cards, and then we'll proceed from there. Are you ready?
Yes.
Very good. There we go. It's good. Oh, good catch. Well done. And now what I'm going to ask you to do, I'm going to ask you to open the box of cards. And I'm going to ask you, please, well done, to hand the box to your colleague to the right, to your left, my right. Well done, yes. If it had been to the other side, we would have had to worry about a thought disorder. Now I'm going to ask you to go through the cards in a moment. And as you do, I'm going to ask you to please to find a card that you like. No, not a joker, because I'm a joker. I'm going to ask you please to find a card that you like. And once you do, I just want you to take that card out. Please go through now. Do not tell us what it is. I'm going to ask you, found your card. I'm going to have you take the deck now. Turn it face up, square it toward the ceiling, and then I'm going to have you put your card in face down. Perfect. And then I'm going to ask you to borrow back the box. And then I'm going to ask you to put the cards back into the box. Please be certain to close the box. That's critical. Thank you. Now, I'm going to ask you to throw the box of cards back to me. Good throw. Thank you. Thank you. Thank you. Last night, at 3 in the morning, I awoke from a sound sleep in a dream. And I dreamt we were going to do this today. And so I got up from my sound sleep and went over to that box of cards and opened the box up and went through, and I took out one card. And I turned the deck face up. And I put the one card in face down. And then I put the cards back in the box. And there the cards have been since 3:03 a.m. this morning. Now I'm going to ask, please, for you to share out loud with all assembled the actual card you selected. It was the
King of Hearts.
The King of Hearts. In this deck of cards, there is one and only one King of Hearts. And we are looking for the one and the only face-down card. Please watch my hands. No rapid movements. Nothing up my sleeves, but my arms, my fingers never leave my hands. I remove the cards. I asked you not to select the Joker because I will take the Joker and I will put it under the deck so that I can't get to the cards. And we're going to go through and we are going to look for one face-down card. And only one. And you see, there is one face-down card in this deck. Yes, and only one. And you selected one card, am I right? And you took that card and turned it face down into the face-up deck. And I'm going to ask you, please, to remove, without looking at it, that face-down card. What was the card you selected?
King of Hearts.
Let's see if we have a patent dream as you turn that card over and show us what is the card. It is, in fact, the King of Hearts. Thank you all very, very much. I look forward to seeing you all tomorrow morning, and we'll do even more. Thank you.